Hi everyone, my name is Rachel Moses and you are watching the YouTube Leader Live. I am so sorry, there was a slight delay there, it just wasn't letting me connect between the two different platforms. I'm delighted today to be hosting this live streamed free YouTube event, Everything About Long COVID. Now, we're not going to be able to cover everything in one day session, so I do apologise in advance, but what we're going to do is give you a flavour of what we know now, what the evidence tells us, particularly about lived experience, and add in a real multidisciplinary element to this. So I'm not going to take any more time. I'm going to ask the panel to introduce themselves and then we're going to get on to the first speakers. But just a reminder that you do need to be logged into YouTube to access the chat. You can only access the speakers and ask questions in real time. This session's going to last an hour and a half, so please do, or reach out on social media and I'll try and keep a look on both. So over to you first, Dan, to introduce yourself.
Hi everyone, I'm Dan Ibkani. I'm a principal statistician in the health analysis and life events area at ONS.
Thanks, Dan. Nisreen.
Hi everybody, I'm Nisreen Alwan. I'm an associate professor in public health at the University of Southampton and an honorary consultant in public health at University Hospital Southampton.
Thank you. Ben.
Hi, I'm Ben Humberstone. I'm the Head of Health Analysis and Life Events at the Office for National Statistics.
Thank you. Ami.
Good morning, I'm Ami Banerjee. I'm an Associate Professor in Clinical Data Science at University College London, and I'm a consultant cardiologist at Barts and UCL Hospitals Trusts.
Thank you, Ami. And Darren, over to you.
Hello, I'm Darren Brown. I'm a clinical and academic physiotherapist. I'm also a person living with long COVID and one of the founding members of Long COVID Physio.
Thank you. So this is session one you're watching of a full day event and it's entitled Data, Science and Epidemiology. So Ben, I'm going to hand over to you and Dan for the first presentation. Thank you so much.
Thank you very much, Rachel, and thank you so much for organising today. We're really privileged to be here and excited to present the results of two studies that we've done on long COVID at ONS. Really pleased to be talking to allied health professionals and to get the information that we've been able to produce using our analysis and data out as widely as possible. So the two studies that we're going to talk about, the first one is based on something called the COVID infection survey, which is a large survey. We've got about a sample of about 400,000 people. So as surveys go, it's a whopper. We take swabs and bloods. We follow up on a weekly basis. Follow respondents on a weekly basis for the first month, and then once a month for the next 12 months. So we get a good longitudinal view of people's contracting and infecting or infection with COVID-19 and then their ongoing symptoms. Who will talk through that. The second study that Dan will cover is an observational study that we did using health data that was or linked health data, looking at multi-organ impairment of those post-hospitalization who suffered with COVID-19. So if you could move on a slide, please, Dan. Thank you. So the first thing to say is that in the survey that we're reporting on here, we're talking about self-reported long COVID. And that was really important to us. We asked people whether they had experienced ongoing symptoms after COVID-19 that couldn't be explained by anything else. And that was really important for a number of reasons. Number one is it didn't rely on a positive test. So people could report as having long COVID without a positive test. And when you think back to the start of the pandemic, where the testing wasn't covering, there wasn't complete coverage in terms of testing, it means that we pick those people up Second point is that it reflects people's lived experience and the real lives of people, rather than relying on a diagnosis, particularly where the clinical diagnosis for long COVID is currently unclear, and others will talk about that later. So what that ended up with, the figures that you see here are for the 4 weeks up to 6th of March. So pretty much 12 months on from the start of the pandemic in the UK, and the estimate is that 1.1 million people have long COVID symptoms. We've got a list of 21 symptoms that we ask people about that include the symptoms commonly presented with by or presenting in those with long COVID. So things like fatigue, cough, sort of cognitive brain fog type thing, and Nisreen will talk more about those later. So of those 1.1 million, about 700,000, 697,000 first had symptoms at least 12 weeks previously. So we're talking about a large number of people having symptoms for at least 12 weeks, and 70,000 of those had symptoms for at least 12 months. Well, those 70,000 contracted COVID-19 before the peak of the first wave of the pandemic. So we expect that number to rise as we continue to take this survey over the next few months, but it's a significant number. And the reason that we're interested in all of this is because number one is to provide information to the NHS in terms of clinic numbers and funding and the likely pressures on the health service, but also thinking about the social and economic impacts of long COVID. We asked specifically about the limiting impact of long COVID and the extent to which people's day-to-day activities are limited. And you can see there that we've got around about 200,000 people of that 1.1 million whose activities are limited a lot. And if you think about what that means that people might not be going to work. So we need to think about the impact on the benefit system and other and the workplace and the workforce. People might not be able to care for dependents. People might not be able to do the things that they had taken for granted before they had contracted COVID-19 and gone on to develop long COVID. So the second chart there shows the prevalence by age group. And again, what we see is that the prevalence is highest amongst the working age population. So 35 to 69 on that particular chart. And that's important again, because a lot of day-to-day activities and workplaces and so on will be affected by long COVID. As we learn more about it, we will be able to extend the detail that we can provide around that in terms of who's affected, what are the likely impacts on society and the economy. So we'll continue working on that, and as the sample survey goes on, we will collect more information from individuals who are impacted by long COVID. If you contrast the chart on the screen there to mortality from COVID-19 has a very steep age gradient, and the bulk of tragically the bulk of deaths are in those 70 plus. It's quite different to prevalence of long-term symptoms, where the age group is more sort of 35 to 69. Some describe that as sort of middle age. I like to think of 35 to 49 as young adults. So that's what we're showing. There is a difference in terms of sex as well. Next slide, please, Dan. And what we see there is the percentage of those with long COVID symptoms, that is symptoms that last more than 4 weeks, in the dark blue bar, and greater than 12 weeks in the light blue bar, is greater for women than men. It's about, overall for the population as a whole, it's about 1.7% of the population have long COVID. By sex, it's 1.9% for females and about 1.5% for males. So that would explain that. The other point to mention, just on the age breakdown, is that it's about 2.5% of the population aged between 35 and 49 who have long COVID symptoms. Next slide, please, Dan. What we wanted to do was just rule out that this is something happening in the general population, and that this reflects something different, like lockdown, or it isn't related to COVID-19, but there's long-term prevalence of symptoms for disease and ill health amongst the general population. So we took a sample of the survey who had a positive test for COVID-19. So that was about 21,500 people, and we matched that sample. So we matched on age, sex, and enrolment in the survey to a set of control participants who hadn't had a positive test for COVID-19. And what we found was that the symptoms experienced by those who'd had a positive test at the 12-week point were 8 times higher than those who had not had COVID-19. And you can see on the chart there the sort of survival curve, which shows that around about just over, well, nearly 14% of those who'd had COVID-19 had had symptoms at 12 weeks, whereas in the general population, the prevalence of long-term symptoms is much lower at about 2%. So that's what we've done so far with the COVID infection survey. We are collecting information on vaccinations as the sample grows that we're talking to, because it's longitudinal. We're adding to it all the time. We will be able to do more breakdowns by ethnicity. A couple of interesting patterns that we have found is that there's a higher prevalence of long COVID symptoms amongst the most deprived areas in the UK. So we use the index for multiple deprivation, and we break it down into quintiles from the most deprived 20% to the least deprived 20%, and the prevalence is highest in the most deprived 20%. We've also found higher prevalence amongst health and social care workers, and we're breaking that down at the moment to look at the roles and posts that those individuals do, so we can be more precise about exactly what the impact is, to try and give people a head start in terms of determining what the physical mechanisms are for those long COVID symptoms. So I'll hand over to, well, no, I think there's one more slide for me, Dan. So this is the age and sex breakdown for that particular study, the 21,500 with a positive test. And as you can see, the dark blue bar shows those who have tested positive, and the green bars show the control participants. And while the pattern is broadly the same, you can see that the difference in the prevalence of symptoms that last more than 4 weeks compared to particularly 12 weeks compared to the general population. So I'll hand over to Dan now, who will talk about the next study.
Thanks, Ben. I'll just try and stick my mic and my camera on. So yeah, thanks a lot. So morning, everyone. So this is a slightly separate study. So this was published recently in the BMJ, and this was a piece of work we did in collaboration with Ami at UCL, who's on the call today, and colleagues from University of Leicester. And the aim was to investigate post-discharge outcomes following hospitalisation with COVID-19, using electronic health records for all NHS patients in England up until September last year. So we had about 90,000 individuals in hospital with COVID-19 during the study period, and around 60% of these have been discharged alive by the end of the study. We excluded patients with unknown age or sex, those who couldn't be matched to control patients. So this was a case control type design, and this left us with about 50,000 COVID-19 patients with a mean follow-up time of 140 days. Just trying there we go. So we looked at the baseline characteristics between discharged COVID-19 patients and compared these with a random sample representing 0.5% of the general population. So compared to people in the general population, COVID patients are more likely to be male, more likely to be elderly, age 50 or over, more likely to be living in a deprived area, and more likely to be overweight or obese according to their BMI. COVID patients are also more likely to have a pre-existing condition than people in the general population, most notably hypertension, cardiovascular disease, respiratory disease, and diabetes. So given these imbalances in the characteristics between discharged COVID patients and people in the general population, we one-to-one matched our 48,000 COVID patients to controls on the basis of these demographic and clinical characteristics. And we did this using 10 years of historical health records across nearly 50 million NHS patients in England. So this slide shows the event rates of adverse events post-hospitalisation. So as I say, we had a mean follow-up time of 140 days after discharge. We found that 1 in 3 COVID patients were readmitted hospital within this mean of 140 days, and more than 1 in 10 patients died. We found the post-discharge event rates were greatest for diabetes, major adverse cardiovascular events at around 130 diagnoses per 1,000 patient years each. So in this study, major adverse cardiovascular event includes heart failure, myocardial infarction, stroke, and arrhythmia. Compared to individuals in the general population, matched on demographic and clinical characteristics, discharged COVID patients experienced higher rates of diabetes, cardiovascular disease, kidney disease, and liver disease. And in particular, the rate of major adverse cardiovascular event was around 3 times higher in COVID patients than in matched controls from the general population. And rates of adverse events remained elevated when considering only the incident cases, which is shown in the chart on the right. And here we excluded anyone with a history of these conditions from the analysis. So these results demonstrate that patients discharged from hospital after COVID-19 experience higher rates of multi-organ extrapulmonary dysfunction than we might expect, given the background rates in the general population. And these results don't confirm a causal relationship between COVID-19 and morbidity, but they do suggest a statistical association which warrants further investigation. So in terms of absolute risk, rates of all post-discharge outcomes were greater in patients aged 70 plus than in those aged under 70, and in the white population compared with in ethnic minority groups. But when we look at relative risk, which is what's shown in the slide here, we can see that rate ratios comparing COVID patients and their matched controls are greater in individuals under 70 than those 70 or over. So younger COVID patients were 14 times more likely to die than their matched controls, compared with 9 times more likely amongst patients aged 70 or over. And ethnic differences in relative risk were greatest for respiratory disease, with rate ratios of 11 times in the non-white group compared with 5 times in the white group. So what this means is the increase in risk of adverse outcomes following COVID-19 hospitalization doesn't appear to be confined to the elderly, and it doesn't appear to be uniform across ethnic groups. So our results demonstrate how rates of adverse events are elevated in COVID-19 patients compared with background rates amongst similar people in the general population. But we could have asked a slightly different question. So we could have asked, how do post-discharge rates for COVID patients differ to those for patients with other serious conditions, for example, other infectious diseases or other chronic illnesses? So in this study on the screen now, this represents over 2,000 military veterans in the US. This study was published in JAMA last December. And what it shows is that discharged COVID patients were found to actually experience a lower 60-day readmission and death rate than those with pneumonia or heart failure. But there does appear to be a period of elevated risk in COVID patients over the 2 to 3 weeks immediately following discharge. So overall, the risk of post-discharge readmission or death appears to be similar, or perhaps even slightly less in COVID patients compared with those admitted for other reasons. But that's not to say we shouldn't worry about the after effects of COVID-19. So in absolute terms, the rates are still substantial, and they largely represent excess risk over and above what we'd normally expect in the general population in any given year. Okay, so what about organ-specific impairment? So this is another study. This is using a similar design, similar data sources to our own study. It's a slightly smaller cohort of COVID patients, and it's matching on slightly fewer control variables. But the authors found elevated rates of post-discharge organ dysfunction in COVID patients compared with the general population, which are the blue hazard ratios here. And this is in line with our own results, similar sorts of outcome events. But the study also went on to find that outcome rates in COVID patients were comparable to those seen following pneumonia, which is represented in terms of the yellow dots here. So again, this study provides evidence that the risk of adverse outcomes following COVID-19 hospitalization is similar to that for other serious conditions. But again, it's important to recognize that for many people, this represents excess risk. Most people who were hospitalized with COVID-19 wouldn't have been hospitalized with pneumonia had they not been infected with coronavirus. So this is additional risk over and above what we'd expect in a typical year. So what are the areas for further research, at least from our perspective as statisticians with an interest in public health and possible consequences for socioeconomic inequalities? Well, in terms of population prevalence of subacute symptoms, it's not clear how the vast number of people reporting symptoms on a survey are going to translate to diagnoses and referrals in clinical practice. As Ben said, we found that around 2/3 of people self-reporting long COVID said their symptoms were having an adverse impact on their day-to-day activities. And clearly these are the people who are most likely to present in primary care. But it's not clear which symptoms or which groups of symptoms are most highly correlated with activity limitation. And if we're able to infer this, then this could inform the treatment pathways being offered to patients in clinics. In terms of post-COVID organ impairments, a number of studies like ours have recently been published with a focus on patients hospitalized at the acute phase of infection. But organ dysfunction in non-hospitalized individuals has been far less well characterized. There have been some studies, such as the CoverScan study, which I'm sure Amy will tell you about shortly. These have demonstrated multi-organ involvement and mild impairment in low-risk individuals, and these have really shed some light on the underlying disease mechanisms. But further research is needed to understand the long-term incidence at a population level. Research studies of hospital patients have shown that risk factors for prolonged symptoms include middle age, female sex, and 2 or more comorbidities. But overall, the evidence is mixed, and risk factor studies outside of hospital settings remain scarce. And finally, the potential socioeconomic burden of long COVID is clearly huge. We know that early attempts are being made to quantify this, but it's not going to be possible with any level of precision without reliable population level estimates of the impact on work, the impact on education, and the impact on health and social care needs. So happy to take any questions at the end of the session. Feel free to drop us an email or get in touch via Twitter using the details on the screen. Thanks very much for listening.
Thank you so much to you and Ben for that first presentation. I'm going to move swiftly on to our second speaker, and thank you everyone for all the comments in the chat. Please do keep adding them, where you're from, where you're listening from, and any questions. Over to the phenomenal Dr. Nisreen Alwan, who is definitely becoming and is an expert in this field. So thank you very much.
Hey, I'm here, yay. Can you hear me?
There's a slight problem with YouTube today, so thank you so much. I'm so glad we've got you back. Over to you. We can hear you fine. We can hear your screen, yeah.
And you can see my screen, so that's brilliant. Okay, Hi, everybody. Thank you so much. Well, thanks so much, Rachel, for inviting me to this great event. I look forward to, I've enjoyed obviously the Ben and Dan talk so far, and I look forward to the rest of the to this event. So yes, I'm Nisreen, and some of you might have heard me before, so I'm going to skip over, but I always find it very important to say where I'm coming from when I talk about long COVID. So where I'm coming from is that I am a public health doctor, an academic and an epidemiologist who in March 2020 got COVID-19 symptoms. And I was like the rest of you, basically I had the same narrative, is that, I'm in my age group with my particular health background, I should be at low risk. So I'm in the white bit of the screen where, I would be getting short-term kind of flu-like symptoms at the worst, and then I'll be just fine. And that was a narrative at the time, and that is actually still frustratingly the narrative for still for many people. But we do know now that we've got this people who are in the middle, the gray area, so not necessarily people who are very high risk of getting admitted and dying from COVID, but people who do not recover. And unfortunately, I was part of that kind of gray area where I didn't fully recover. And it's really important I always try and say, it's really important that we don't mix survival with recovery. Again, we're in the second year of the pandemic, and this narrative is still the same, is that, confused, survival versus recovery. People survive, but then, a lot of them don't recover. So then I started a few months in, and me kind of validating my experience through the amazing social media activities, social media, platforms, and people tweeting or going on Facebook and saying, well, we're the same and we're not really recovering, and these symptoms are weird and they're coming and going. So in the summer of 2020, I had my professional hat on as well. And I thought, wait a minute, we're epidemiologists. Nobody is measuring this. Nobody's quantifying this in any way, which is the illness from COVID-19. Everybody's just talking about number of positive tests, called cases, which we all know that, it's not, a lot of people weren't tested. So that's not all the cases, but, hospital admissions and deaths, and nobody's quantifying the illness. And this is the bread and butter of what we do. We look at mortality, the deaths, but we look at morbidity as well and try and quantify it, because that's important for the burden on a population level as well as individual level. So I started talking about that. And then there was the first BMJ seminar in September, which was great, because it kind of started talking about what is long COVID. And I think where we are now is much better, but I think there's much more to do in terms of the understanding and the research, as you'll and the recognition, as you'll hear through the rest of the day. So what is long COVID? Well, it is a patient-made umbrella term, which I definitely maintain till now that it is an appropriate term, because our understanding is not deep enough now to move on to other terms. So that's my personal view in terms of, using the term. It could be, several conditions, depending on where we are in terms of characterizing it, as research moves on. I would define it as not fully recovering from COVID. So you're not going back to your normal baseline health before you got the infection, whether that's weeks or months. There'll be different cutoffs, being used in terms of what after how many weeks, you get classified as having long COVID or post-COVID conditions, etc. And I'll touch on case definitions a bit later. So we know it happens in even so-called mild COVID-19 cases. And actually, there have been more recently accounts of people who were asymptomatic, and if they were tested at the time, and then they would develop these strange symptoms, and their health deteriorates, not necessarily at the time where they were diagnosed, which is the window of the acute infection. That is very difficult. That adds complexity to the picture, particularly for those who've not tested. So they didn't have the acute symptoms, and then they didn't get the lab confirmation of the infection. It can be very debilitating. It's a wide range, and I'll talk a bit about the range from the survey we did. Dan and Ben talked about the prevalence, and I want to take this opportunity to say a huge thank you to Ben and Dan and their team for providing these really, really important estimates of the prevalence of long COVID, because this is something that was greatly needed. So thanks for that. There have been studies looking at the prevalence, but mostly are much smaller than the ONS study. Collating the evidence from the other studies as well, I would put the estimates around that, and that, you know, in those initially hospitalized, it seems to be very common that they don't fully recover after discharge from hospital. So over half of them in most of the studies. In terms of those who weren't hospitalized or mild or moderate initial infections, I think most of the studies point to kind of 1 in 3 people after a few weeks, and then between 1 in 10 to 1 in 4 people after 3 months from the onset or testing positive. It's really difficult to accurately measure, and we're gathering more about that now, mainly because first there's this relapsing nature where you're not always, for many people, you're not always the same level of ill all the time. It comes and goes, and some people actually goes completely and then it comes back, and for some, you know, they get much better. And also the symptoms don't all stay static all the time. So there's a huge complexity in terms of defining recovery. And then the huge problem of lack of lab confirmation. So, and which I'm going to talk a bit more about later. And then how do we get these estimates? We get them from studies that might be biased in terms of who they're looking at. And I'll touch on that a bit later as well. So. I think that was from, I like your statistics so much, Dan and Ben, so I knew you were going to present them, but I thought I can't miss this slide because it's a great slide looking at the prevalence by age group and by, you know, males and females. So I think Amy might also touch on the mechanisms, but very briefly, we still don't know what the underlying mechanism. We don't know if these things can coexist in people, but these are some of the proposed mechanisms. You know, whether it's inflammation, you know, fibrosis, so organ damage, whether there's an overdrive of an immune reaction in a similar fashion to autoimmune diseases, whether there's some persistent virus that's not been excluded, you know, some low levels of persistent virus, that's another hypothesis, and what if there are any role of genetics and other risk factors. So what we did a few months ago is we did a survey of, you know, people who were in support groups mainly for long COVID, and they were mainly based, the responses were mainly based in the UK because we wanted to characterize long COVID. How does it look like? So in the slides that you see, the percentages in brackets is because what we did is we analyzed our whole sample, but only about just over a quarter had lab confirmation of infection because they were mostly first waivers, because the duration of illness was about over 7 months for them. So there were the people who weren't tested in the first wave because people didn't get tested then unless they got admitted to hospital largely. So the numbers between brackets are for those who have lab confirmation, and it's just really to show you how similar they are to the overall sample, which includes people who were, you know, who don't have that lab confirmation of testing. We had an over-representation of women, people with university degree, and people from white minority, and this is not surprising. This is what you would get really from surveys usually in terms of, it's not surprising in terms of research in general. So it's not really a representative survey, but it can give us a picture about, you know, what the illness looks like. 90% of people said they had good to excellent health before the infection. The pre-existing condition were, the top ones were asthma, high blood pressure, and hypothyroidism. So they weren't necessarily disabling for people. And so one striking thing is that long COVID seems to be very predominantly a multi-organ system. So 84% had at least 3 different organ systems involved, rather than just being limited to, you know, the breathing or the chest or, you know, the neuro symptoms. So it's a multi-organ system, and the pattern in 3/4 were that fluctuating, relapsing, coming and going pattern. And you can see from here the actual the symptoms, and the blue bars are the those who you know, not lab confirmed, and the pink bars are those who had reported that they were lab confirmed, whether by antibody or PCR testing. And the main, so you see the most common symptoms are exhaustion. We didn't really ask about fatigue. We didn't phrase it as fatigue. We asked as exhaustion because we had extensive co-production in terms of, you know, patients looking at the questions before going. And I think the consensus was that, you know, what is exactly fatigue, that needed a bit more defining. The cognitive dysfunction, which is the second most common symptom, was a combination of 4 things. So if they had any of these things, they fit in that category. It's what people call brain fog, poor concentration, poor memory, and confusion. And then you've got, thirdly, you've got breathlessness, headache, then muscle aches, palpitations. If you put chest tightness and chest pressure together as questions, they become the third most common symptoms. We asked about chest pain, chest tightness, and chest pressure because there were these different patterns emerging of the sensation that people were feeling in their chest. So a third of people said they weren't able to live alone without assistance at 6 weeks from onset, and 2/3 took significant time off sick work, and over a third said they've lost income specifically due to to long COVID. And you can see the massive effect on people's life. So the ability to self-care, half of the sample, doing domestic chore, work, childcare, caring for others, and obviously affecting their mental health, you know, the symptoms they were having. We also asked questions to come up with this fatigue severity scale. So that's separate from asking about exhaustion, and that and basically the score was more than 4, which is more the kind of the normal cutoff in 84%, in 86% of people in the survey. And then there was another scale, which is the post-COVID-19 functional status scale. And you can see that, you know, about a third of people had severe functional limitations, and another third moderate. And basically you know, in terms of the patterns, what we tried to do is try and cluster. So we had 2 main clusters. And the main message from this slide really is that the majority of people were in cluster 1, and that was characterized by having the chest symptoms, which is the, you know, the pain, breathlessness, palpitations, the cognitive symptoms, and then the overall exhaustion with it. And if we look back at the acute symptoms to try and see what predicts progression, we find that they have tended to improve a bit, apart from the cognitive function, which seems to, for some people, appear a bit later in the illness. And then the minority cluster had basically, what we can see is they've just had more of everything in terms of the groups of symptoms. And if we look back at their acute symptoms, they don't seem to have improved. In fact, you know, there's some tendency to get worse in terms of having more symptoms. So hopefully we can do a bit more work about that in terms of what symptoms predict what, but other studies should be doing that too. So where we are in terms of what what are the priorities for long COVID, the 3 R's are, I tend to go with them, and these are largely what the APPG, so the All-Party Parliamentary Group, demanded in the first parliamentary debate in long COVID back in January. Reporting is really, really important. I've been going on about this for ages, so I feel like a broken record. And reporting is not only estimating the prevalence, which is great, like the ONS and the other studies have done, but it's actually, doing surveillance. So as we're reporting number of cases and the number of hospital admission and deaths. So, the numbers we hear every day on the news, the dashboard that we have, we need a statistic there about long COVID, because that's important. That's the measure of morbidity from the pandemic. We can get it from following on people who test, although that won't be comprehensive, because not everybody would have tested even now, or we can get it from electronic health records, patient registries, people accessing care. But we need really good diagnostic criteria and case definitions for that, and I'll come to that in a minute. The recognition is everything that we need to do for people, and it needs to be independent of lab confirmation. That's really, really important, because there's huge discrimination in terms of recognizing the illness of who got access to testing, and we need to still recognize there are huge barriers for testing for people, because people who test need to isolate. There are huge financial, social barriers against it still. And then obviously the debate about the occupational illness, because we do know that people who are in certain occupation more exposed to COVID, so therefore they would be more likely to develop long COVID. And then you've got the clinical management, which I'm sure there'll be much more discussion on later today, but that's the physical, clinical assessment, and the investigations, the treatments, the rehab, and then that goes into the primary care and long COVID clinics that we have here in the UK, and we need equitable pathways for that, and obviously policy. So this all would fall under recognition. And then the research, we've got so many unanswered questions. Dan touched on them a bit earlier. I've got a slide with some of them at the end. But what I really like to make, the point I'd like to make here is that we need the multiple methods for this research, because electronic health records are a great way to try and study conditions, and it is a great way to look at long COVID. However, there are limitations, because coding has only recently started for long COVID. So what people get coded out as would likely be biased, and also who gets to access healthcare and gets recorded. So we need the surveys, we need the qualitative research, and talking to people with lived experience. And we really need to include disadvantaged people who, some of them might be even living with long COVID without knowing they've got long COVID. Mostly you would know you've got long COVID, and then you try and access the service to access support and care. So the case definitions are really key. We need something to introduce inequality and reduce the variations and who gets that long COVID recognition. So the NICE came up with these definitions, which gives some time cutoff. So the post-COVID syndrome, as it was called in NICE, would be having these signs and symptoms which are consistent with COVID, which continue for more than 12 weeks. And not explained by alternative diagnosis. So what are the signs and symptoms? There needs to be more research, because obviously there will be clinical variation in terms of what recognized and coded, but also the other bit is the bit about not explained by an alternative diagnosis, because as Dan has shown, people are developing other treated organ damage and pathologies. Whether that gets counted as long COVID, whether people move out from the long COVID category, once they've got that, this discussion needs to happen and be open, because that affects the quantification. So, so this is just a paper recently. We start really thinking about how we can achieve some sort of more universal case definitions. And one suggestion is to kind of go back into the acute illness and say, well, if you didn't have the test, or you didn't have the antibody test, but you had some certain criteria in terms of the acute symptoms that you had, and where you were at the time in terms of what was the prevalence of COVID at that time in the area, then that may provide a bit more uniform way to try and recognize, well, that's what, you've got that, and now you're experiencing symptoms, continuing symptoms, or relapsing symptoms, and so therefore you could be classed as long COVID. Just to limit the time, these are the kind of again, going back to basics in public health, we look at preventions, primary, secondary, and tertiary. So we always have to talk about prevention. The pandemic's not gone, it's still here. So we need to prevent the acute infection. We need to try and prevent, cases from developing. And that is the primary prevention of long COVID, not getting COVID in the first place. And then once you get it, can you actually prevent progression? What sort of interventions can you have to prevent progression? One thing that's been talked about is rest and the acute illness. In our survey, we did some analysis to see whether rest was linked to having that severe cluster. And we did find there was a link between people reporting they've had adequate rest in the first 2 weeks and going to that, that being preventive against going into that second more severe cluster. But that, again, there'll be limitations around that in terms of how people, in relation to their current symptoms, recalling kind of the adequate rest at the start. But there could be pharmacological treatment in the acute phase, which have now largely been really focused so far on the more severe cases. But the tertiary prevention is really preventing people from getting worse complications, more disability, and improve their quality of life. So COVID, we know COVID is not an equalizer, and that was the idea at the start, that it's an infection that could happen to everybody. Well, no, we know the huge inequalities introduced by COVID, and there will be huge inequalities, and there are huge inequalities. This is my expectations. We don't have the research yet in terms of long COVID, but that's evident also from the testimonies of patients in terms of who can access care, who can get adequate rest, who can take time off work, and who gets exposed to COVID in the first place. And we know there are inequalities there. I want to touch, I've got two more minutes. First of all, I want to touch on stigma, because this is really huge. We've seen stigma as an important aspect, and we've seen it with other illnesses and infections before, such as HIV, ME, and chronic fatigue syndrome. And this is, long COVID is not proving any different. And we've got different types of injustices. So there's an injustice in terms of people, being dismissed by the systems or by service providers because they don't understand. There's little knowledge about what long COVID is, and therefore this could translate into being dismissed. And also there's nothing to offer, maybe. So, in terms of what can be done for these patients. This is exacerbated by structural inequalities. We do know that certain groups in the population, women, people from ethnic minorities, people from more deprived backgrounds, tend to get more dismissed. The really painful one as well is the internalized stigma, because if you keep getting dismissed, not only by services, but even by the people around you, in terms of the symptoms you're feeling and the illness you're feeling, you then could develop this kind of feeling of shame and guilt about having the illness, and that could prevent you from further talking about it and accessing support and services, and it's a kind of downward spiral from there. So really important to talk about this. So we need these things from the health service. Listening is really important, and the recognition for people who are accessing patients that even if there's no immediate fix for the symptoms and the illness, the listening and recognition is very, very important to do, and it's a positive thing that the healthcare professionals can offer patients, in addition to all of these other things. I'm closing now just by some questions on research, and Dan already touched on some of them. I suppose what I'd like to add to what he said, I mean, we want to know the mechanisms, we want to know who's more at risk, who's more likely to recover from long COVID, because there are people recovering from long COVID, and what are the factors or predictors of that. We want to know more about the clinical patterns, particularly how the acute symptoms lead to the chronic symptoms, and how we can prevent them if possible. The role of the vaccine, and we want to know, still there's this question about reinfection, people long COVID given, depending on what mechanism it is, whether it's an dysfunctional immune reaction, etc. What are the likelihood of them getting reinfected with or without the vaccine? And then the inequalities and stigma really needs to stay in the agenda of research, and quantifying the burden. I added the last bullet point, although all of this apply in children, but I thought I want to stress that long COVID exists in children. There have been much less research, even though there's not much research on long COVID in general, but much less in children. So again, thanks to the ONS for doing the breakdown by the age groups, because that's really helpful, but we need more research to look at long COVID in children. Even if we are seeing that it tends to less common, we do now know it occurs, and given the scale of the infection, that's a huge problem as well, because we don't know the long-term health implications for our children from this. So thank you so much. I'm sorry if I went a bit over time, but let me share it. Okay.
Not at all. That was absolutely sensational. You are on fire. You are on fire. My DMs and my Twitter notifications are going crazy. So thank you so much for that. You're going to stay for questions at the end. We do have some in the chat. I'll send them on to you. But thank you so much. And thanks for all you're doing in this field as well, being a long COVID survivor, sufferer, and campaigner. So thank you. Ami, coming over to you next. Thank you so much. Dr. Ami Banerjee is going to be discussing his specialist interest area, and thank you so much for joining us, another social media activist in this area. Thanks, over to you.
Thank you very much, Rachel and team, for the invitation, and thank you for organising such a great event. And thanks to Nisreen and Dan for, I think they illustrate the power of data, and then Nisreen, research and advocacy, how that influences policy. So I thought about what I should talk about, and I guess a lot of people want to know the specifics of care and care pathways, but actually there's so many questions that I'll try and sum up the data that we have, but I also think it's important to think of the context in terms of policy, the clinical picture, and then the care. So I'm a cardiologist, and I'm also a data scientist and epidemiologist, and usually my day job is in cardiovascular disease and non-communicable diseases. I have research interest in global health. And so you might be surprised about why I'm interested in COVID and long COVID. But I'll try and explain that to you shortly. My conflicts of interest are that I'm a trustee of the South Asian Health Foundation, which looks to ameliorate health inequalities by ethnicity. I'm an advisor to the World Heart Federation Emerging Leaders Programme, and I have unrelated research grants from AstraZeneca around chronic diseases. So it's been a long year for all of us. So I had COVID myself in the end of March, beginning of April, but I was lucky in some respects that I haven't had long COVID, but I'm surrounded by colleagues and family members who have had long COVID, and I've lost colleagues and friends and patients to this disease. So that's my motivation first. But if you look at the timeline at the top of this slide, just to remind ourselves, the first death was seen in January of last year in China. The first cases we saw in the UK at the end of January, the first death in the UK in March, early March. And the WHO was looking at the people who are highest risk for mortality from COVID and for hospital admission. And at the same time, we had recommendations from Public Health England, from the CDC on the other side of the pond. And that was really when I and my team at UCL got interested in looking at how we can predict and prevent what was an impending disaster. And we published a preprint in March, and that was published in the Lancet in May to show that there would be over 70,000 deaths over the next year if there was a 10% infection rate over the population over a year. And clearly we've exceeded that. But when we did these analyses, there were 79 deaths. So I want to, first of all, make the point that this is avoidable. We must not forget that this is avoidable and preventable. And Nisreen eloquently said that long COVID happens on the back of COVID. So stopping COVID and infection in the first place is the key to this. If we go back, I want to make the point that risk prediction tools have been a focus of the literature from early on, how to predict who's most at risk. And there were over 60 when we counted in February, but only 2 of these tools have involved patients and public, and neither of those explicitly said what they were doing in terms of process to involve patients. So there's a mismatch there between the research that's been done and the involvement of patients, even before we get to long COVID. And that was the direct effects on mortality, but the indirect effects was something that we in clinical practice have seen. So this is the impact on people who have cardiovascular disease and the care they were receiving early on in the pandemic. And so our health systems have had a double whammy before we even get to long COVID of direct impact and indirect impact, leading to strains on the health system, leading to backlogs of care in non-COVID services as well as COVID services, and also strains on individual health professionals. So that's the backdrop. And we've been, as Nazreen said, focusing on acute, hospitalized, high-risk patients, and we've been focusing on mortality. So we had our blinders on when it comes to long COVID. And the worry is, when you look at today's headlines, this is a pandemic. It's a global problem. A lot of the data that I'm showing and others are showing are obviously UK focused. In India, where I have family, the record numbers of cases are still continuing to rise. Same in Brazil. And the long tail of the pandemic is in the form of long COVID. So we started, or I should say my industry colleagues at Perspectum started a study in April of last year to look at long-term impact on organ function. There was no term long COVID at that time. They just wanted to see what was happening in the different organs in terms of function. And so they devised a one-stop MRI assessment, which takes between 30 and 35 minutes of different organs listed here. And it's interesting, at that time, they couldn't get ethical approval to look at controls. They couldn't get ethical approval to do a really long assessment, a full comprehensive assessment. So that's why the scan emerged as it was. So in the first 201 patients of a study that has recruited over 500, we published the first data in the cover scan study in BMJ Open. And this was in preprint in September. It reached the journal after peer review in beginning of March. And so again, it's just to reiterate that journals are working quickly, but there's still delays in the gap between knowledge and getting it in the public domain. So we showed clearly, as Dan I think has mentioned, that there is mild impairment in people who are predominantly, so to the right of the slide here, 201 patients, only 18%. So 18% were hospitalized. So the most of them, 4 out of 5 of them, were non-hospitalized. And we did later recruit controls with an amendment and compare, and found that across all organs on MRI evidence, there was evidence of mild impairment by published criteria. So, for example, in the heart, which is what I do as my day job, there is clear evidence of myocarditis. And that has been reiterated by several other studies in the UK, such as within the FOSS study, the Seymour study, and from around the world as well. So there is clearly a subset of patients, even in the non-hospitalized group, who seem to have signs of involvement of the heart and other organs. How that progresses over time, what we need to do to treat that, these are open questions. In our study, we're following people for at least 6 months, and we'll be in the next month or two able to show that data with full 6 month, and for some patients, 12-month follow-up in terms of how that organ impairment plays out. On the left of the slide, I want to mention that MRI assessment of the liver here, which is already done, already approved, can show fatty liver disease, which is a precursor to chronic liver disease. And people with this evidence on liver MRI had 5 times the likelihood of needing to be hospitalized with COVID, which is from the UK Biobank. This is another study that we published recently. So it's this idea that chronic disease, or at least the signs of chronic disease, even in people who might not know they have the chronic disease, seem to be a risk factor for mortality we have from the pandemic, but also whether it's a risk factor for long COVID symptoms seems to be hopelessness by the MRC scale, whether in terms of functional impairment. And we clustered symptoms. And so the kind of headline findings, if you will, were even in this small group of patients, there's a high symptom burden in clustering in people based on the severity of functional impairment and severity of breathlessness. And on the right here, myocarditis stands out in that group. And I should say 201 patients, it was a research study, so not in usual NHS care. And so this is a study that needs to be grown. We need to evaluate our cover scan MRI technology in the general care pathway. But already you can see this is clear evidence that there is organ impairment. So we developed, I guess, a policy recommendation when we published that BMJ open paper that ideally we need to be, as Nisreen has said, reducing the population infection rate, so improving testing, tracing and isolating, which I've got very tired of saying throughout the pandemic, like many people, but still we're in a situation where our tracing and isolating is inadequate in this country and in many countries. But that's the best way to prevent long COVID and the one that we know will work. Managing baseline risk, so looking to identify any chronic conditions and treating those that we identify, monitoring symptoms. And we haven't got a baseline assessment, but we do in the cover scan have something that can, in one comprehensive way, look across organs. And that can also be done over time to evaluate the recovery in organ function or the progression of organ impairment. And so this is a technology that has an emergency use authorization from the MHRA. It's under application for breakthrough designation from the FDA in the US as well. So that means that this can be used and it needs to be evaluated. We're currently putting together a grant proposal to do so, but I think this needs to be done because at the moment, as I'll come to shortly, the care pathway is such that people are getting investigations in different ways in different places. And sometimes, for example, in the heart, they might end up with several different heart scans. So we need to make sure there's some standardization. I won't dwell on this because Dan has very, very clearly shown the risk of chronic disease. So we have been wearing the lens of looking at chronic diseases as increasing the baseline risk of mortality. That was how we were thinking. So this was a surprise to many people to see that there is an association with new onset diabetes, cardiovascular events, chronic kidney disease, chronic lung disease. This is in hospitalized people. We need to have this scale and length of follow-up in people who are non-hospitalized as well. Dan and Ben have shown that there are 1 million people or more just in the UK and several millions around the world. We are still at the stage in terms of our evidence generation where we're doing either small cohort studies, surveys, or case series. That's not acceptable. We need to be finding this out quickly so that we can plan our services. This is unpublished data, not yet even on preprint, in patients from the clinic that my colleague Melissa Heitman set up to assess and manage patients with long COVID at University College London, which has been running for over a year now. And I've just got a couple of slides here, and this is preliminary data, not yet peer reviewed. But I would say that, to reiterate what Ben said, I think there has been a functional impairment such that in people with long COVID, the proportion of people, even in the non-hospitalized group, who are able to work full-time, if that was what they were doing before their illness, or part-time, if that's what they're doing before, has dropped substantially. About half of people are working as they were before their illness. So the economic impact of that is enormous in a group who are classified as low risk in traditional risk prediction for COVID mortality, and the scale that Ben has described. We need to look at different symptoms and different clusters of symptoms in terms of functional impairment. So here, the blue lines are individuals with brain fog, and the red line is people with brain fog. The blue line is people without brain fog. And the proportion of people who have their optimal health, as reported by them, is much less in people with brain fog, which is perhaps not surprising, but this is one of the symptoms that stands out in this regard. So we need to do more of this clustering of symptoms and looking longitudinally at outcomes. I want to talk about the gap between acute and chronic COVID care. And if you look at the top here, the timeline I've already shown has been busy globally in the UK around research initiatives, funding. And it's important to know that in February, the first COVID funding call, February 2020, first COVID funding call was announced by NIHR. The recovery trial had started, and we already had results within the month about remdesivir and dexamethasone within a couple of months, risk prediction tools and so on, and obviously vaccines rolled out in the UK in December and around the world. Compare that with long COVID, where there was a post-COVID dedicated clinic set up in University College London. There was guidance, and through patient-led advocacy, there was the first NIHR long COVID call, and we've now got a second long COVID call. But there has been less activity, less funding, less awareness of this. And yet, if you look at the middle of, or the top, sorry, of my slide here, and look at the dark blue line, first of all, that dark blue line is telling you about the number of cases, the number of hospitalizations. The bars there are telling you about the number of cases, and the mortality is going up. And the red is data from the UCLH clinic, which unsurprisingly is related to cases and hospitalizations in a staggered manner. But that has also been going up and down with the pandemic, and is still a strain. So I use the term the long tail of the pandemic deliberately, because this is an area where we do need more research, more funding, more clinical practice. Nisreen's already done this, and she's more expert on this than I, but I would say, in terms of prevention of long COVID, preventing the infection is primordial prevention. So infection suppression, whether that's by social distancing, wearing masks and other measures, or vaccination, is the way that we know we can stop this happening. And then the progression is from symptoms to impairment, which is physical, mental, and functional. And we want to stop that being long-term. We still see people a year on or more who haven't yet recovered. And what we want is to increase the proportion of people who are recovering and support them so that they can be discharged from formal services. And this term, which many people are using, including colleagues like Brendan Delaney and Trish Greenhalgh, we're also interested in this idea of integrated care, rather than looking at different components of the pathway. Looking at, you have to look at the whole thing. You can't just look at investigation without thinking about treatment and rehabilitation and so on. And it's a bit like that's the story of the blind men and the elephant. If you don't do it that way, then the cardiologist is only interested in the myocarditis, the physiotherapist is only interested in the rehabilitation, and so on. And we're not thinking holistically about long COVID care, which is what we have to do, because we already have a burden of a burden to individuals, 1.1 million people in a prevalence study. So we need to be delivering care in the best way we can already. So this siloed approach is not going to work. And I would propose that we also need to think in our data in a learning health system type of way. So the learning health system model, for those who may not be aware of it, is from the field of health informatics. And there's science data that is discovery, if you like. There's evidence where data is used to inform guidelines. And there's healthcare, which is the delivery of care to patients. And we haven't got time to only do these things in series, where we have to properly define and look at the pathophysiology of long COVID, and we'll only look at the care once we've done that. We have to be doing all three of these in parallel in this kind of circle. Otherwise, we'll be looking to develop treatments after the pandemic. There is an inequality in many ways with long COVID already in terms of services. Despite the rollout of long COVID clinics nationally, I was quoted in this article, it's not only a postcode lottery, there's a lottery of knowledge as well at the moment. So in terms of expertise and experience in different parts of the country, or even within regions. Just, I think, 2 more slides. So the syndemic is a term that has been around for a while, but it was used in this context by Richard Horton during the first wave of the pandemic. And this is this idea that even though this pandemic is due to coronavirus and infectious disease, it's indissolubly linked to non-communicable diseases and social determinants of health. And so some of the inequalities that you see before, some of the needs for management and treatment before the pandemic of non-communicable diseases need to be seen as well during this coronavirus pandemic. There's some good news on the scene in the last week. So to fit with this idea of chronic diseases, this isn't specifically in long COVID, but 2 studies, one in the Lancet Respiratory Medicine and one in preprint, have shown in community-based patients in the early stages of coronavirus, if they're treated with budesonide, which is an inhaled corticosteroid, their recovery is quicker, basically, and they have a milder course with coronavirus infection. This is a treatment for diabetes, an SGLT2 inhibitor, dapagliflozin, which has been tested and shown in hospitalized COVID not to have an effect. So the thinking there was that a treatment for chronic disease might improve function. But we need to see more trials being done in this patient population at scale and quickly in parallel, so that we can get answers. And the negatives are as important as the positives in terms of drug trials. So to conclude, the research and care car at the moment has, as before the pandemic, been driven by specialists, both on the research side and the clinical side. And we talk about data-driven care, and patients have been passengers, sometimes not even in the front seat, they're in the back seat. That in a moving target, which is where we are right now, with a scale of disease burden that we see in long COVID, is not fit for purpose. Specialists are the sat-nav at best. The data is the engine, but there's only one group that should be in the driving seat. As William Osler said many years ago, just listen to your patient, he's telling you the diagnosis. So to conclude, prevention is best. We need to look at a big picture level and zoom out about why we are where we are. And even now, there is a role for infection suppression and making sure we recognize people with long COVID. I hope I've convinced you that joined up integrated care approaches are the way forward. I think we have to remember that this is a global pandemic, and we have to think of this globally, whether it's in terms of prevention or in terms of treatment of long COVID. And I'm reminded of the global burden disease study, which when I was at medical school, we were taught that there was no non-communicable disease in low middle income countries, which was later shown to be a totally flawed assumption, because we weren't measuring non-communicable diseases in those countries. And we definitely weren't measuring morbidity. So similarly, we were only measuring mortality and acute effects of the pandemic. We need to measure long COVID and morbidity. There needs to be parity of funding of care and research for chronic disease, even beyond the pandemic, and patient-driven is the only way. Thank you.
Wow, thank you so much. I am going to invite all of the speakers on. We're probably going to overrun by 5 minutes, just everyone, which is still have a 10-minute break before the next session, partly because of the delay. Straight into questions here. Darren, I am going to go over to you and just kick us off, co-chair. Thank you.
I want to say thank you to all of you for presenting what you have, because not only the research that you do, but the advocacy that comes with that has profound impacts on people living with long COVID. And there are three key things that have really come out for me personally from all of the presentations that you've done. So first of all, it's validating. Long COVID is real, and that actually there is stigma associated with that still. And there are things that we can learn from other health conditions that have experiences of stigma. The second is all of you presented data on the functional impacts that people are experiencing and the fluctuating and episodic nature of the disability that people are experiencing. And from my own experience, that has been quite profound in terms of the episodic, unpredictable and multidimensional nature of the disability that I have experienced. But lastly, I wanted to thank you, not only for promoting that we must count this, but that also there are inequalities that are profound throughout this. And so therefore we must be holistic and to take an approach that's been from HIV and AIDS, the greater involvement and meaningful engagement of people living and affected by this health condition, to use your term, Amy, must be at the steering wheel. So I want to say thank you.
Thank you. Now, lots and lots of questions. I am going to come in to you first, Ben. So 3 or 4 questions about comparative data for other countries, and also with regards to other post-infection symptoms for coronaviruses, so the SARS, which was on obviously a much smaller scale, but are we looking at any comparative data?
So we are looking at comparative data where it exists. There's an awful lot of studies that are starting up now. There's some studies that are spread across the EU and South America and elsewhere. They're predominantly clinical studies. So the type of population level estimates and prevalence estimates that we've been producing are few and far between. Certainly something like the COVID infection survey, but they are developing. There have been, so I think the first population level study of long COVID was actually in the Faroe Islands, and there hasn't been the level that we would have liked. Our estimates have been covered well around the world, and there's a lot of interest. We've been contacted by a lot of other countries looking at what we've done and how it can be replicated. But it's as I say, the clinical level data is developing, and we're engaged with that. The population level and the social and economic impacts, I think we're at early stages, and there aren't that many comparators around the world compared to what we've done, but we continue to work with partners around the world, particularly from things like the impact of the vaccine and so on. What we've seen in Israel and elsewhere, where they've got similar vaccination rollouts to in the UK, and we'll continue working with them.
Thank you. And this is a massive shout out from a frontline clinician for the incredible work of the researchers, the academics, the statisticians, everyone working incredible hours from home in the lab. So, and I think you've just beautifully summarised that, the three of you, in those presentations. So from the clinicians, thank you so much as well. Nisreen, this might be a really quick yes or no, and I think it was answered in the question, but there's 3 or 4 questions as well come through social media about the correlation of disease severity and viral load in those that were PCR positive, given worse outcomes for those with long COVID. Is there a correlation that we're seeing?
Not that I know of. There have been studies around acute outcomes and severity, but for long COVID, there haven't been evidence that I know of correlating viral load at the start and severity of long COVID. So,
thank you.
Unless the others know of, but I haven't seen anything on that.
Can I just jump in? No, I agree, Nisreen. I haven't either, but that is data that we collect on the survey. So when we swab test all our infection survey participants. So there is that's something we're working on right now. So in the next couple of weeks, hopefully we'll be able to see the evidence coming through from that.
Wow.
Well, there you go. And just a very quick one, Dan. Again, I'm not sure this can be a straightforward yes or no answer, but is antibody testing useful or reliable to confirm if someone has had COVID in the post-acute phase?
So again, that's a marker that we collect on the infection survey. I think it's in terms of testing, I think that's about as good as we're going to get, I think. So I think it is. I'm not a virologist. I'm not a medical practitioner. But as far as I can see, I think that's Nisreen might be able to jump in and say otherwise. But yeah. I think that's about as good as we're going to get in terms of actual kind of diagnostics.
I think just to jump in and say I agree with Dan. If you've got it, if people have a positive antibody test, particularly in the absence that's before the vaccination, then that would be that's one of the criteria we suggest, just to say, well, if you've got the antibody positive and then you have symptoms afterwards, then that's long COVID. But it's really important to note that they're not reliable. So if you've got a negative antibody test, that does not rule out that you've got long COVID, because there have been evidence about waning antibodies, even in people who've had documented positive antibodies. So they get tested again and they go away, and people struggled. Many long COVID patients struggled for months to get an antibody test. So if you get out to 6 months and it's not there, you could have had the antibodies. And the other thing to quickly add is there have been some hypotheses about whether there's correlation between actually having the antibodies in long COVID. So is it something about people with long COVID that makes the antibody levels low? So some sort of dysfunction around, the antibodies themselves as a mechanism.
So if I may just add, so what Nisreen just said is really important, that, when we did the cover scan study, because of the timing in the early first wave, there was even worse access to testing. And so inclusion criteria was either a positive test or clinician diagnosis by two clinicians. And reviewers in journals were not happy with that. And that is the disconnect between academia and journals and the real world. They want a really clean study in a real world problem where clinicians are faced with real problems. So if you want to answer clean scientific questions in a laboratory, you can. But if you want to do things that are relevant to patients and healthcare, then you have to be able to accept and interpret that messiness. And I would absolutely echo what Nisreen says, that we must, if we can get antibody testing, great, but that shouldn't be an exclusion in our studies and our practice.
We've, in speaking to patient groups right early on, they were very clear that there were people who had negative antibody tests but felt that they had the symptoms of long COVID, and it couldn't be explained by anything else in their experience. So we've been very careful to make sure that we, that our survey is as inclusive as possible in terms of the patient experience or the lived experience, rather than any specific tests. So we're agnostic about a positive test, PCR or antibody.
And just very quick to say that actually in our survey and other studies as well, if you had PCR positive, the people who've got PCR positive but then antibody negative. So even with those lack of confirmation, you could have. So I suppose it's really important. We went on about this, but it's important for all practitioners not to discriminate based on negative antibody tests. That's the main message, because it's really not a good marker, particularly in terms of specificity. So if it's negative.
Thank you. Now, I do think this is an important question, and we're seeing this. I've seen some of the long COVID data from the clinics we're going to talk about later on. So the pre-hosp COVID study showed white women were more at risk given disproportionate effects of COVID. So what we're seeing from the Public Health England disparity report, I think this is referring to, on mortality in ethnic minorities. Is this just related to the demographics being included in studies? So why we're seeing a difference in those long COVID and the acute? Nisreen, maybe coming to you first.
Yeah, I mean, you kind of touched on this. Really, is the representativeness of what you're measuring, and I think I mentioned that if the hospital, hospital studies, so, clinical studies, health record studies in this context have this caveat, because it's entirely dependent on who's accessing the service and what gets coded in the records. So, if, women from ethnic minorities, are accessing less because of this, not because they have them less, but it's because, the pattern of access, health-seeking behavior, and the kind of the stigma and the recognition by the service could determine that. And I'll give you another example. I mean, there was a recent study in the Lancet about long COVID, focusing on neurological and psychiatric symptoms, and the most common difference was in anxiety compared to controls. And anxiety is definitely present in many people with long COVID, and mostly secondary because of all that's happening and the unknown nature and what we talked about, the stigma. But I think they depended on clinical records. So we know from lots and lots of patient testimonials that people would go to the GP, they would describe these symptoms which were largely unknown to the professional, and they would get that diagnosis of anxiety. So that gets coded in the records, and then if you have a study looking at the records, that's what comes out. So really need to be cautious about that. Not to do the studies, but to be cautious about the limitations of that.
Absolutely, and reaching out. We've got a session on research next, so please do come and tune in for that. Darren, can I come over to you to ask some questions? Thank you.
Yeah, we've got quite a few questions that have come through specific to the cover scan study. So I might come to you, Ami, if that's okay. Sure. So I'm going to try and combine them. So the first is more around, is the level of organ impairment higher than you would expect if we were to scan the general population? So is this actually clinically significant? And then the follow-up to that is, what are the scans or investigations that should be done? Because most people do not have access to, for example, cardiac MRIs to determine myo and pericarditis. So what tests should be being performed in clinical practice to identify these organ impairments?
Thank you, Darren. In our study, we didn't, as I told you early on, we didn't get ethics to do healthy controls. And so we have a very minimal number of controls. Because at the beginning, people were worried about, why do you want to expose controls to excess risk of infection? And that needs to be done. But so two things. One is that, fortunately, we find mild impairment. We didn't find any severe impairment. So that's a positive thing. But that was quite common. From other studies, so MRI studies don't tend to look at the general population across lots of organs. So I think we have to do that in the general population. But when we compared with controls, which is the best data we have, it seems to be more than we'd expect. Which tests should you do? So if you look at NICE guidance, which is expert and consensus based, it's not evidence-based, because we don't have that evidence at the moment. They recommend simple tests done at the time of referral or prior to assessment in the post-COVID assessment clinic, namely ECG, chest X-ray, perhaps 24-hour ECG monitoring, and blood investigations. But at the moment, most places are either developing their own specialist pathways for which symptoms or which particular findings on those tests will lead to more specialist investigations, because we don't want to be doing tests on everybody. But there's big variations, even in 1 or 2 centres. You know, when you talk to clinicians in the same centre, and that's a problem when people are doing different things. And that's where I think there is a role to evaluate whether a one-stop comprehensive test at some point in the pathway is value adding. And you're right to say that not everywhere has cardiac MRI or access to certain exercise function testing and so on. And so that's something we do need to look at going forward.
On that note, around maybe the disparity or the differences that have been done in different places, obviously there is a England-specific but UK mandate for the provision of long COVID clinics. For the whole panel here, is there a drive to have a nationally mandated data pooling of what sort of tests should be performed in these clinics? Or is this just different depending on where the clinics and what they're doing?
So I'm not sure if the same is planned in Wales and Scotland, for example, but I think it is eventually, and there have been efforts to try to standardise the pathway, but I think that everybody's got their work cut out at the moment, because as Nazreen and Dan have said, there's problems with the definition of the disease. There's gaps in what we know about treating and managing the disease. So which pathway to implement is challenging. And that's why I think having data gathering at all steps of the pathway in a standardized way is important, so that we can, drop the bits that we don't need and focus on the treatments that do work and the rehabilitation that does work.
Thank you so much, everyone. So I am just so grateful to all of the speakers today on their day off, working incredible hours. I'm really, really grateful. Please do reach out on social media. I'm very aware we haven't answered all of the questions. Please just tag these people in, tag myself in, and we will get them answered. We're going to have a 10-minute break. Please rejoin, or just keep the YouTube link open and you'll be able to access the next session on research. Thanks very much, everyone.